Thank you very much. This is our first annual Inspired Spine conference for pain management. I'm going to give a 15-minute talk about the nature of pain, and I'm hoping in most of the hospitals that we are operating, people will have access to this recording that will be available later on the YouTube. First, we are going to talk about a little about the nature of the pain. What is really pain? There is a genetic disease that these kids are born with pain receptors being absent. Practically, they don't feel pain. By the time these kids are 4 years old, they have lost their fingers. Most of the time, before the age of 10, they have lost their feet and hands because they don't learn from avoiding from the painful stimuli, avoiding damaging encounters. And that's almost a philosophical question. Is pain good or bad? Now, we know burn is painful, but what may some people not know, that the 4th-degree burn, where practically all the skin and the pain receptors are destroyed, is virtually painless. These patients feel no pain whatsoever, and if you go to extreme, they have no pain. So it becomes a philosophical idea what pain is and is it good or bad. But let us a little talk about the infrastructure of the pain in our brain. The way I talk to my patient, pain is a signal. Pain is and this signal in our brain obviously is received no different than any other feeling, but the reaction to that is what makes the pain truly pain. In a house, we have smoke alarms that if something is wrong, they send it to maybe a central place, maybe even some monitoring place. And that we have the similar structure in our body that are very specialized to gather the information about the pain and send it to our brain over certain pathways. I'm not going to go into the details of how this infrastructure is set. That's a different conversation. That's a different talk, which is significantly longer than this talk. But we have significant amount of information and knowledge about these pathways. We are able to modify them, these pathways. There are multiple receptors involved at multiple levels that we can medically, with medication, or surgically, with surgical intervention, intervene, interact, and work with. Now, what I'm going to talk to you about, though, that most of the time, the pain, what we assume as pain in human being, is an emotional response, what we have to that kind of stimuli. And as a matter of fact, we used to do a procedure called cingulotomy, where we very precisely approached one of those pathways in the brain where the response to the pain was produced. Once we lesioned that area we did that for obsessive compulsive disorders, this patient would perceive the pain at the highest level, but the response was, my pain is 10 of 10, let's go have a coffee. So the emotional response was separated. So for them, pain was no different than noticing that they have something in the hand. As well, I think what we need to understand is what is the difference between the chronic versus acute pain. This picture shows a branding of a cattle. And if you watch that online, you will see that cattle just stands up, goes around, and starts grazing as nothing has happened. Because in most of the animal kingdom, the chronic pain has no function. And practically, the chronic pain is a human-specific kind of reaction. If I guess somebody would brand a person, that person wouldn't just stand up and go about doing the regular activities. The emotional response to that would be much more massive. Now, what is pain? Pain, we are going to categorize it in many different areas, but what we call nociceptive pain is the damage is being done and something, the biological structure need to do something about that. Again, I'm not going to talk about all the pathways that are well described in how this is from the stimuli on the molecular level to the receptor, to the nerve and pathways, but what we know that we can modify the pain from the original place where it's produced in our receptors, in our periphery. And most of the non-steroidal medication that we use these days, like aspirin, ibuprofen, they actually modify the receptibility of these receptors in our extremities. Now, we have as well the significant other kind of modifying medication that along this pathway in our spinal cord or in other places influence how this signal of the pain are passed through a certain level of neuron to get to our brain. But at the end of the day, we need to understand that there are multiple different kind of pain. The pain can be a real pain, like a nociceptor pain, that something is burning in your hand, avoid it. But the pain could be as well produced if the neuron that produced that signal shooting wrong signal, like a smoke alarm that it's just broken and it shoots wrong signal. Another kind of pain that we need to be very aware of, especially in the spine, is the fact that there are some pains that are produced actually in our brain itself. And as a matter of fact, we call them so-called psychogenic pain. We cannot confuse them with the malingering, means somebody who's pretending to have pain, but has no pain at all. A psychogenic pain for the person who's receiving it is no different than somebody who got his arm cut off, because these pathways are stabilized in the brain, and in his mind's eye, and at the end of the day, every kind of pain is in the mind's eye. It becomes a real entity. Now, here, I wanted to look at that. It's always a matter of perspective. This is a very famous picture from the Buddhist monk who put himself on fire. And the people who have observed that, they say he had no response, or he was in such a meditative state that for him, all that pain that we can assume has been significant did not provoke any emotional response during that procedure. Now, what we need to understand as well, a different kind of pain, what we call phantom or central pain, where in a way there are actually two different things. In the phantom pain, a limb that is separated, the end of the neuron that are cut off, they send a signal. And in central pain, practically the progression of the phantom pain, like in what we call thalamic pain, the end of those neurons that end up in our thalamus, which is a relay station of our brain, shoot those pain signals. Now, and again, we have significant knowledge about that. I'm not going to go to the details of that. Like here, we see something called syrinx, where a cavity inside of our spinal cord is created, and that sort of makes a short circuit in our neural structure that carry over the pain signals. And in this case, for example, we feel pain that's actually generated in the spinal cord itself, because those neurons are being pushed or under pressure in that location. Now we are going to go through a certain category of pain medication. We talked about non-steroidal, which over certain molecular path modify our pain perception at where the pain is produced, meaning at the skin level, extremities, or internal organ, and so on and so forth. We have a very good understanding of how they work. Now, opioids mostly works on the certain receptors that relay that pain from the original place to our brain. They have as well some effect on our brain perception of the pain, but how they work is mostly on the relay station of the pain. We have a very good molecular understanding of that. And this is a complex kind of talk by itself. And we can talk the whole day just about the opioids, how they work. But and there is lots of controversy now, and Ali is going to talk about many of those controversies. Most of Ali's talk is actually concentrated around the opioid pain management. But what I want to know is, first of all, are they working? Yes, they absolutely work. Opioids are very effective managing the pain. How our organism deal with that is the problem, because we have a direct up and down regulation of the receptors that we get physically on the molecular level used to it. And again, we have significant understanding what those receptors are, how this works. There are multiple receptors, and we are not going to talk about that. For the immediate post-operative care, though, we have few good tools to use that. And I think nobody in the medical community will argue that the opioids are crucial to perioperative pain management. Now, for example, PCA, the patient-controlled analgesia, where we produce a pump and we program it at certain level, and patient can give themselves pain medication, has been shown to be very effective, very useful. But we are not going to talk about PCAs today, so let's move on. There are many factors as well that we have a profound understanding of how we can modify everything that is around the pain pathways in our brain, and what we call adjuvant therapy. Like there are the medication that can modify how the pain system in our brain communicate with other system. A good example for that is known for 40 years, are antidepressant medication, that we know by properly managing the depression, we can reduce the pain response, pain level, and pain medication. Another thing that it's very well understood these days, and more research need to get done, are the use of cannabis in pain management. Our best understanding of the pain management with cannabinoid is that they as well cut the relationship between the pain receptors, pain system, and emotional response to that in a memory solidification process, meaning that they interrupt pain to get engraved in our memory system. But the fact is that in many studies, we know that they reduce the amount of the narcotic is needed to manage the pain. Now, there are some other ways of managing the pain, including for certain kind of pain, like spastic pain, botulinum toxin has been used, and some surgical ways to stimulate the pathways in the spine with spinal cord stimulation device, or even deep brain stimulation, especially the subgenual area of the cingulate gyrus has been very useful to centrally control the pain and respond to that. But let's go a little more, talk about the actual management. I think in the hospital, if you're somebody in one of our hospitals managing our pain, we are going to talk about actual pain management. Vistaril has been a very good medication in the last 10 years to manage pain, especially in spine patient. It has multiple effects on multiple systems, and one of them is only the sedation. And in combination with some muscle relaxant, opioid has been shown to reduce the amount of the pain medication. So most of our patients are these days actually on Vistaril. I come back to that. Let's talk about another medication that has been, at least in the last 4 years, a mainstay of our pain management in actual patient in the hospital. And that medication is ketorolac or Toradol. Toradol is as well a medication like most of the non-steroidal, a COX inhibitor that works on where the pain is originated. There was some question about the effect of that on coagulation, and if immediate post-operative patients are a good candidate for that. At least we can say in Sparspan, as a matter of fact, for minimal invasive, this has been a very good medication with extremely low to non-side effect. At the beginning as well, we had some question about if it's a medication that has a large side effect on the kidney and so on. And the way we use it in our postoperative patient, meaning using it for 2 to 3 days, scheduled dose, we have not have any, in our 780 patient, any side effect regarding kidney failures regarding that. So it has been shown to be a very good medication in our patient group in the surgery and after the surgery immediately. Now, as well, there are many questions in our postoperative pain management about Valium versus Flexeril. Both of them, they have the spasmolytic effect, but the Valium has a central effect. And in our patient group, we have found that Flexeril is extremely superior to Valium because we want our patient to stand up and walk 2 hours after the surgery, but we don't want to centrally sedate them. With Flexeril, we get the spasmolytic effect with very little central effect, and we are always in favor of Flexeril. Additionally, there is a question about using neuropathic or anticonvulsant pain management, especially gabapentin is a big. Our take on that is with a good amount of experience that if patient has been on Neurontin before, we will continue that after the surgery. As many of you know, especially gabapentin, this is not a PRN medication. This is a medication we start at 300 once a day, slowly go up to 900 TID. In the hospital, you can do it faster if you have a good cardiovascular monitoring, but outside of the hospital, obviously slow up and slow down process. And if I get a patient who get 300 TID, practically we know that this is really not what this medication is not doing much for them. So I think 600 to 900 TID is the minimum amount of gabapentin that really has a measurable effect. Now, it's a very safe medication. It's a very effective medication. As we have discussed before, a certain number of our patients get a neuropathic pain, and we try not to start the gabapentin right after the surgery. We usually wait 2 weeks after the surgery, if they have not been on gabapentin before, to see if their neuropathic pain goes away. A certain number of our patients get that. But a 2-week period is a good time to start gabapentin. If they're outside hospital, go slowly up and keep them on 900. If somebody starts on gabapentin, that's the last medication we take them off medication, meaning that after all narcotic and other medication are off, then we start weaning them off gabapentin. Now, we are going to talk about some practical tip about our patient right after the surgery. Many of our patients have been in pain for many, many years. Those pain pathways has been stabilized. And we just have to know, for everybody involved, the pain patients are painful to everybody, to their surrounding, to their family, to the hospital staff, to the mailman. And we just as professionals need to know that and deal with that in a professional way. We as well need to know regarding the pain management. We, especially after the surgery, we have to start it early and be in the front of the way. Many times, if we wait for the pain to be at 8 or 10 of 10, it's hard to catch up. And the pain management starts before patients wake up. We can come back to that, what to do. And another thing is that many of medical professionals, they become themselves emotional about pain management. Like if they have a personal stake at giving or not giving pain medication, I think a good idea about that is completely being rational about that. After the surgery, doesn't matter how much pain medication you have given to our patient. If patient look into your eyes and is awake, alert, oriented, and says he's in pain, and we don't fight the patient. We give them pain medication. We just have to know our ABCs and control the vitals and so on and so forth. We evaluate the patient each time before giving pain medication is never a reflex. There are always evaluation and management on the fly. And as well, what we need to know is pain management. Pain is PRN, or pain med is PRN for pain, not for annoyance. Meaning that if a patient is just asking you 5 times for pain medication, but your breathing is shallow, and the patient cannot have direct eye contact with you, and just because he's annoying us, we don't give pain medication for that. There is a evaluation before, and those evaluation is mostly the ABC, as everybody's aware of that, what they are, and then the pain scale, and so on and so forth. A question about as well, can I give the patient Valium? I'm asked that question very often. In Inspired Spine, we treat the pain. We don't sedate the patient. We need those patients awake, moving around, and because we are planning to send the patient home same day or next day. And from in 1950s, our practice after the surgery was to not give the patient food until they have bowel sound or even bowel movement. And at least for the last 40 years, we know that we should not do that. We should feed the patient, even after abdominal surgery, we should feed the patient as soon as possible. If we give the patient who is on empty stomach, especially narcotic, practically we are guaranteeing that we are going to have an ileus. So our patient after Inspired Spine, we don't have to wait for the bowel sound or passing gas. We feed them right after the surgery as soon as they are not nauseous. The concept of waiting for the bowel sound or bowel movement or passing gas to feed them is an old concept. It's a half a century old concept. Now, additionally, what we tell to the patient that they need to ambulate. They need to ambulate early, and they need to know that it's going to be difficult. Many times the nurses tell me, you know, he was so painful, he couldn't ambulate. And that's why, you know, patient, you know, who got the surgery at 11 a.m. at 6 p.m. still hasn't ambulate. Again, at least in the Inspired Spine, we have significant evidence that they can ambulate within the 24 hours. As a matter of fact, 95% of them do so. And we have to encourage them. It's going to be difficult no matter when you do that. As a matter of fact, if you wait, later on, it's going to be even more difficult. We get physical therapy, we work on the ambulating them the right way. It is like a magic though. As soon as they ambulate, they start improving much faster. And coming back to that, again, early ambulation, early feeding, and but as well, we need to understand that we have to do our homework. We need to know our limits, and we have to evaluate the patient each time before giving pain medication. We are not going to know a practical way how we manage Inspired Spine. We give Toradol before they wake up in the PACU already. We don't wait, and we give obviously additional to what anesthesia does, hydromorphone, which has a shallow bioavailability, meaning like contrary to fentanyl that peaks up and peaks down, or morphine that is much better than fentanyl in that regard. The hydromorphone gives you a more steady dose, and our dosage is 0.2 to 0.6. And we can give it every hour, or we can give multiple 0.2 dose or the PACU. And the threshold there is pain level of 6 and above, or even 5 and above. Especially in the PACU, if the patient is already monitored, we can be pretty generous with that. Norco and Percocet are good medication. We like actually the combination with acetaminophen, that it actually makes the effect much more pronounced. And here, obviously, patient need to be able to swallow. The nausea and so on right after the surgery can be difficult. within the first hour after the surgery. But most of the time, I believe just even in the PACU within the first hour after the surgery, this should start. We shouldn't wait 6 hours after the surgery on the floor before we start the PO pain medication. Flexeril it's a good medication to start, as well as Vistaril. And as well, you see in our pain management, I have put 7, 8, 9 is start the ambulation as soon as possible and setting the expectation before the surgery. Pain level of 0 after spine surgery is not realistic, no matter what you do. But patients need to know that. And having a team included in that, not only patient need to know certain level of pain is involved, your surrounding, your team need to know that as well. Now, I need to talk about a little about the pain scale. It is a very subjective meaning that many of our patients, they look at you, they smile, and they tell their pain is 10 of 10. Yes, it is a subjective, we can react to that, but the pain scale as reported by patient cannot be the only measure for us for PRN pain medication. Your subjective pain is a vegetative symptom. If somebody is in severe pain, their heart rate is high, they are hypertensive, they are diaphoretic and so on, or respond to the pain reported by patients should be add to that our own management, our own pain evaluation. So this is something many people who are in the spine, they hear. Doctor, I'm allergic to all pain medications, especially Toradol. Only Demerol works for me. You don't hear that many often anymore. But for many people who are as old as I am, now Demerol has been a very, very specific medication. And if you look at the bioavailability of Demerol, you see that it has those peaks. It gives patients the highs. So if somebody is allergic to every medication except one specific medication today, Demerol is fentanyl. And so if you're managing the pain, you have to know what medication gives you the highs and what medication doesn't. I think the best balance there in the hospital is actually the hydromorphone or Dilaudid, and outside of the hospital, a combination of Norco or Percocet. Now, what we need to know as well, something very specific about what Inspired Spine does and the pain management. One is open surgery, one is MIS. There is no question, in the long run, the open surgery is more painful. But for immediate perioperative, sometimes MIS can be more painful because we are preserving all those nerves. Let me go to the very first slide here. I need you to understand that the most painful burn is grade 1, where practically we have the best chance of healing because everything is preserved, all the tissue is alive, and the most painless burn is grade 4. Now, let's go back and understand that if we catch up, if we managed even this patient properly, in our study group, in the MIS, even though we preserve all those pain nerves, their pain management has been much better than the open surgery. But the fact is, these patients go home just one day after the surgery. And now, I guess this is what maybe a take home for people just want to have one slide. Pain is not a bad thing. Pain is what saves you, saves your life. And pain is not the damage itself. Pain is the noise of the smoke alarm. And non-steroidal, practically what you do, you cover the smoke alarm. In opioids, you reduce the volume of that smoke alarm, and the neurostimulation and other surgical means that you use. But we do practice, you put your headphone so you don't have to listen to the noise of the pain. And the adjuvant therapy is the good friend that distracts you from the pain. And we all know that works. If you have a tooth pain and you get engaged in a stimulating conversation with your good friend, your pain is less noticed. But we need to know, none of those put the fire out. Sometimes there is a real fire, and we have to take our patients seriously. And we have a track record that patients who have been in tens of years of pain and dismissed as a so-called psychogenic pain, they come to us, we do the proper diagnosis, they have an organic disease, and within 2 weeks after the surgery, they are off narcotic. And I think that's the message. Every pain needs to be taken seriously, and we have protocols in spine exactly to do that. But if the fire is there and everything else has failed to put the fire out, at the end of the day, we do have to call the fire department. If needed, we need to take the walls out to put the fire out, because I think in the long run, not only is the right thing to do for the patient, but it's the cheapest way to manage pain in the bigger picture. Now, I'm done with my presentation. And in the last few decades, I think we doctors have maybe managed the pain mostly on the medical side with narcotic, with opioids, which are effective, but we talked about the side effect of that. Now, Ali is going to talk a little about the overall tendencies here, what is going on, and what does the data say?
Okay. So this work was done while I was interning at the Illinois Department of Public Health. So some of this data is focused in Illinois. But we'll start with a general introduction. This is actually national data. So these are the number of people who died from opioid overdoses going back to 2000 on the left. And this is for different drugs. So in black here, this black line is heroin. The blue line is fentanyl and fentanyl analogs. And then the gray line are prescription opioids. So what you can see is that starting in the 2000s, the number of deaths due to opioids started increasing. That's correlated with an increase in the amount of opioids that were prescribed in the US. So this is called the first wave of the opioid epidemic. And in the first wave, people overdosed mostly on prescription opioids. So this is the rise of oxycodone is often associated with this time period. But starting in about 2010, you can see the black line for heroin starting to shoot up. And that's what we call the second wave of the opiate epidemic. During that period, individuals started, oxycodone was reformulated to make it harder to abuse. So many people were forced to switch from oxycodone to illicit drugs such as heroin. So the number of deaths due to heroin started increasing. And then what's happened most recently is starting in about 2013 and 14 is the blue line there, the fentanyl and fentanyl analogs have started to increase. So nowadays, the largest number of deaths are actually due to fentanyl analogs. And one of the reasons this may have happened is that law enforcement started cracking down on heroin. And fentanyl is actually much easier to ship and smuggle into the US because it's so much smaller and more potent. So for the same amount of drug, you can get a lot more people high and sell a lot more of that. So you don't need to smuggle large quantities of it for it to be very dangerous. So nowadays, that's driven the large increase in deaths in the last few years. So 2016, I think it was almost 80,000 Americans died of opioid overdoses, which is more than car crashes and gunshots combined. So prescribing has actually started to go down. This is from 2006 to 2015, this graph, and shows the total number of prescriptions per 100 people in the US. And so there's actually an interesting relationship here that deaths have continued to increase, but opioid prescribing is actually going down. So obviously, opioid prescribing is causally associated with the number of deaths due to opioids, but it's not the full story. So nowadays, prescribing is actually going down, but deaths are still going up. So there's a question of what is the relationship between prescribing opioids and people dying from opioids. And the takeaway that we came to, which I'll come to later, is that not everybody who dies of an opiate overdose started their addiction with prescribed opioids. What we also see is there's a lot of heterogeneity around the nation. There's no single story. This is a map of the US, and it's been much discussed in the press. The northeastern states obviously have been hardest affected. We're also seeing increase in deaths in the Southwest, for example, in New Mexico and Utah. But there, the takeaway here is that this is a very heterogeneous epidemic. And also the role that opioid prescribing plays may be different across the nation. So this map shows opioid prescribing per capita on a county level. And it shows that the darkest, the black is the highest level, counties with the highest level of opioid prescriptions. And there is, that map is somewhat similar to the map of deaths, but it doesn't exactly align. So some places there's higher opioid prescribing, but not very high deaths, and vice versa. So this heterogeneity makes it difficult really to understand what the direct relationship is between prescribing opioids and people dying from opioid overdoses. So we'll take a little look at Illinois now, this data analysis that I did. And so just a brief overview, Illinois is the 5th largest state in the nation with almost 13 million people. On the left are the demographics of the state in general. And then on the right are the demographics of people who died of opioid overdoses in 2016. So people who died are much more likely to be male than the average person in Illinois. They're more likely to be urban, so from Chicago. They're also more likely to be Black than the average person in Illinois. So that doesn't actually fit with the national story that's been told in the press. The press always writes about the opioid epidemic as a wide rural epidemic, but actually, in Illinois, rural and urban have been affected, and African Americans are actually more likely to die of opioid overdoses than whites. So these are the drug categories that we'll be talking about. So of the 2,000 deaths in Illinois, about 1,000 involves heroin, 900 involved fentanyl or fentanyl analogs, and 300 involved prescription opioids. So looking at the same graph, this information now over time, we see this pattern that we've talked about before. So starting in about 2010, heroin started increasing at the top. This is the red line. Then in about a little later than nationally, about late 2014, early 2015, fentanyl started increasing. And prescription opioids have increased slowly, but contribute to only about 15% of all overdose deaths. So most people in Illinois nowadays are dying of heroin and fentanyl and not of prescription opioids. So this breaks this same information down by rural versus urban. And I think it's important to recognize that the opioid epidemic is very different in rural and urban settings. So depending on where your practice might be, you might see a very different picture of what is going on. So in rural areas, actually, it's a pretty equal mix of people dying from prescription opioids, heroin, and fentanyl or fentanyl analogs. Whereas in urban areas, at least in Illinois, prescription opioids contribute to a very small percentage of all deaths, whereas most deaths involve heroin or fentanyl analogs. So a data set that we analyzed for this work was the prescription monitoring program. And so now we'll start talking about what people were actually prescribed. So now, previously we've talked about what drugs people died of, and now we'll actually talk about what they were prescribed. So the way the prescription monitoring program works is that when a pharmacy dispenses a Schedule 2 through 5 narcotic, they have to report it to this program called the PMP, Prescription Monitoring Program. And the prescription monitoring program then gives this information to health departments, to law enforcement. This is often used in prosecuting doctors, so-called pill mill doctors. And it also then gives this information to providers who can use it in the clinical care of their patients. The evidence around the PMPs is strong. There is definitely evidence that PMPs reduce the morbidity and mortality associated with opioid overdoses, and that more robust PMPs are associated with greater reduction in opioid overdoses. However, many prescribers do not actually use the PMP. Many report difficulty in accessing it. And there's also a challenge with EHR integration. Most PMPs are not integrated into EHR, so they require people to log in separately, which means many people don't actually do it. So what can we see in the PMP? So the PMP ideally will list each patient's prescription records, and we can look for certain warning signs. So what we consider warning signs is individuals who have more than three pharmacies, three or more pharmacies, three or more prescribers, and who receive early refills of their prescriptions. So receive more opioid prescriptions before their previous prescription is actually expired. So of the people who died in Illinois in 2016, of the people who died of a prescription drug overdose, 60% had more than three or more pharmacies, 75% had three or more prescribers, and 45% had early prescription refills in this is data for the last year of life. So this means if we look for these warning signs, this can help us identify people who are at risk for overdose. What is important to recognize, though, is that what is a warning sign depends on the context. So in rural areas, for example, only 28% of patients had three or more pharmacies. And the reason is obviously that pharmacies are much further away in a rural area. So if you have a patient in a rural area, they might not be able to drive to many pharmacies. So maybe having even two or more pharmacies could be a warning sign. So you have to be aware of what context this patient is in to interpret this information. So now we'll talk a little bit about the actual prescription. So one important thing to remember is that we measure opioid dose in morphine milligram equivalents. So this is based on how potent each opioid is. You have to multiply that opioid with a conversion factor to figure out how much of a dose you're actually giving to that person. Obviously, there's also variability in how people respond. So one person will respond differently to the exact same dose as another person. But to get a broad idea of like what dose you're actually giving to that person, we use morphine milligram equivalents, also called MMEs. So hydrocodone, for example, has an MME of 1. So 1 milligram of hydrocodone is equal to 1 milligram of morphine, whereas hydromorphone has an MME conversion of 4. So 1 milligram of hydromorphone is equal to 4 milligrams of morphine. So of the people who died in 2016 in Illinois, 70% received any opioid prescription between 2010 and 2016. So 70% of the people who died had an opioid prescription. So let's look at how that looks over time. So this is going back 3 years before the time of death. So this graph shows a time course of how many people who died in 2016 actually had an opioid prescription. So 3 years before the time of death, about 250 of them had an opioid prescription. And this is any given day. So any given day, of those 2,000 people, about 250 had an opioid prescription. And that number actually increases before overdose to about just over 300. So we do see a slight increase in opioid prescribing running up to death. And we also see an increase in the number of people who receive high-dose opioids, so more than 100 MME per day. In general, what we see is that dose increases are more dangerous than dose decreases. So these graphs shows how many people had a dose decrease or dose increase any given day. And what we can see is that this graph on the right, it spikes just before the time of death, which means that just before the time of death, a larger number of people than expected had a dose increase. So this is well known that dose increases or giving opioids to people who are opioid naive, who haven't gotten opioids for extended periods of time, it increases the risk of overdose. So the message is that the time that providers need to be particularly vigilant is when doses are increased. We also know that benzodiazepine co-prescribing increases the risk of overdose. Benzodiazepines, such as Valium, for example, are often used together with opioids, and they increase the risk of respiratory depression when used together with opioids. So in the last 3 months of life, of the 2,000 people who died, 600 filled an opioid prescription in the last 3 months of life. And of those 600 who filled an opioid prescription, almost 60% also filled a benzodiazepine prescription. And that number is way too high. And it is a big issue that contributes to the morbidity of opioid overdose. So we do also know, though, we know that 70% of people filled an opioid prescription in the past 6 years before overdose. But that means that about a third of people did not fill any opioid prescriptions. before overdose. And so these are the people who we think are less likely to start their addiction with prescription medicine, but more likely to start an addiction straight away with heroin or fentanyl. And what we can say is that this graph compares people who die who had a prescription to people who never had a prescription. And what we know is that people who die of an opiate overdose who have never filled an opiate prescription are more likely to be Black and Hispanic. They're more likely to be urban, and they're more likely to die of heroin or fentanyl. They also actually have much lower healthcare utilization. I think this is really important. The people who die of opiate overdoses on the left, the people who die with an opiate overdose who had an opiate prescription have really high healthcare utilization. They show up in the hospital and emergency room a lot. A lot of them have been diagnosed with opiate use disorder. Whereas people who die of opiate overdoses who never fill an opiate prescription, those people don't show up in the hospital very much. They're not diagnosed with opiate use disorder as often, and they're not treated as often. So this is a population of individuals who are dying of opiate overdoses who actually have no exposure to prescribed opioids and who are also not showing up in the healthcare system. So these people are easily missed when you're trying to intervene. So there are some limitations to using the PMP data. First of all, methadone that is used for opioid use disorder treatment is not recorded in many PMPs, so you don't see that. Non-scheduled drugs, over-the-counter drugs, obviously are not recorded. Inpatient drugs are typically not recorded. States now share data with their prescription monitoring programs, but it may not include all data that is all prescription that person filled out of state. And then also many people get opioids from non-legal sources. Obviously, that's if you look at someone's PMP record, it's not going to show up. If they got opioids from a friend or family, if they bought opioids on the street, so that's obviously not going to show up there either. So the main takeaway is, first of all, that there's not a single narrative that fits the opiate epidemic, that this epidemic differs, especially between rural and urban settings. You should check someone's PMP record. Warning signs include multiple prescribers, multiple pharmacies, early refills. And you should really be careful when you're increasing the dose and co-prescribing benzodiazepines. There are actually national guidelines, improved national guidelines for opioid therapy published by the CDC. And there's a website that has some really good resources. And I would actually recommend that these resources that are on this website, based on the CDC guidelines, I would recommend printing them out and having them available in clinic, and also referring to them when you're considering chronic opiate therapy. And so I'm just going to finally go through these guidelines very quickly. I think you probably will be familiar with them, but I think it's valuable just to remind ourselves of what the national guidelines are for prescribing opioids. So first of all, the first part is before starting therapy. Here's the things you should remember. Hamid already mentioned this. Opiates are not first line for chronic pain. Opiates are should be first line for postoperative pain and for cancer pain. But chronic non-cancer pain, opiates are not first line therapy. And for some of the reasons that Hamid mentioned, they're also actually not very effective for long-term therapy. Secondly, patients need to have realistic expectations. And also, they need to have realistic and understanding that if this therapy doesn't work for them, they will be discontinued. So this should be done up front before starting opiate therapy. The patients need to understand what they can realistically expect from this therapy. During therapy, first, it's important when you start opiate therapy to start with immediate release opioids. So the long release formulations of opioids were designed and marketed to reduce opiate dependence. But the data actually didn't bear that out. And so we now know that actually long-release opioids, extended-release formulations, are more dangerous and increase the risk of addiction. So the first step should always be immediate-release opioids. I think that's really important. Then prescribe the lowest effective dose. And it is important to refer to the MME conversion when you are prescribing opioids. So up to 50 MME per day should be the limit in most cases. Going over 50 MMEs per day should require extended increased monitoring, and consider adding a naloxone or Narcan prescription so that the family can reverse an overdose if it happens. Above 90 MME should really be very rarely necessary. It's 90 or 100 MME sort of considered a threshold where people have a really high risk of overdosing. And that should really only happen if the dose is going up slowly and there's justification for it. When using opioids for acute pain, you should write short-term prescriptions. It has been shown that chronic opioid therapy and opioid dependence often starts with acute pain, and then it becomes a chronic, becomes chronic opioid use. In many cases, 3 days will be enough, no more than 7 days without reevaluating the patient. Many people in the US, get a large dose of opioids, even just for a wisdom tooth extraction. When I got my wisdom teeth out in Germany, I got 4 wisdom teeth out at the same time. The doctor asked if I had some ibuprofen at home and then sent me home. Whereas most people in the US who get their wisdom teeth removed, for example, get 30-day scripts of opioids, which is really not necessary. Finally, reevaluating harms and benefits of chronic opioid therapy is important. And so this part 3 of these guidelines talks about this. I'm going to go through this really quickly, but almost done. So chronic patients using chronic opioids should always be evaluated for risk factors that contribute to overdose. And the biggest risk factors for overdose is previous overdose. So any history of overdose, any history of substance use is a really big red flag. High-dose opioids, as I mentioned, are a risk factor for overdose. And benzodiazepine co-prescription is a huge risk factor for overdose. We already talked about this. You should review the PMP before prescribing chronic opioids. You should consider urine drug testing before starting chronic therapy. And again, avoid prescribing opioids simultaneously. And finally, the last recommendation from the CDC guidelines is to offer and arrange evidence-based treatment for opioid use disorder. So if you do find yourself with a patient who you think has opioid use disorder, the evidence-based treatment, the standard of care for opioid use disorder is not to discontinue opioid therapy. The standard of care is to use medically assisted therapy with buprenorphine or methadone to help that person with the addiction, and that should obviously be used in conjunction with behavioral approaches. But again, the standard of care for opioid use disorder is medical assisted therapy. Buprenorphine and methadone are the standard of care, and that's really important. I think a lot of people still don't realize that, or consider this to be controversial, but it is actually not controversial. That's the standard of care. With that, thank you very much.
What your data says that being under medical care is actually a very beneficial, that we shouldn't push those patients away even if we know they are narcotic addicts. We should take over of their care, because that actually reduces the risk of overdose.
Certainly, so that's certainly, the CDC guidelines certainly agree with that statement. So, there's some there's in the data analysis I did in Illinois, there's not necessarily, I don't have the data to necessarily show that care reduces mortality, but I do show that people who die of fentanyl or heroin overdoses have lower levels of healthcare utilization. So whether those two are related, I can't say with confidence. But I do think that people who are in care, there are many more opportunities to intervene. So when a person shows up in the hospital emergency room, each time is an opportunity for intervention. Each time that a person shows up at a physician's office is an opportunity to evaluate that person for opioid use disorder and to intervene. So I do think that healthcare utilization is important in intervening for patients. And again, the CDC guidelines certainly agree with that statement. And firing a patient because they're opioid dependent is not acceptable if you do not also provide resources and referrals for addiction treatment.
And yet, in reality, especially among many of the pain management and spine care, it's a frenzy now that if somebody is opioid dependent, discontinue the care completely. And this, I think, this has been fueled somewhat by just this, all the news and all the politicians who get involved in the management of the pain that, especially in the rural area, in Crookston area, in rural Minnesota, we have many pain specialists. These are people who go and specialize in actual patient care for the pain, who the first knee-jerk reaction to somebody who has broken their pain contract is firing them from their care, and instead of identifying maybe all the other aspects that is involved in the management of the care, I think we are going a little in the wrong way right now. From the time that we maybe we did overprescribe, now to a point that we are literally abandoning our patient, especially in the rural area, where probably the next pain management person is 200 miles away. And
I mean, there are no other. So opioid use is a recognized medical condition, and there are no other medical conditions where we would fire patients for relapsing their condition. We wouldn't fire a patient because they have a return of their cancer. We wouldn't fire a patient who has hypertension because their blood pressure is bad. But with opioid use disorder, many physicians, will fire their patients because they have a relapse of their medical condition. So if I think there is still, part of the problem is still there is that attitude that opioid use disorder is not a medical problem, but a behavioral, or like a character problem.
And I think what adds to that as well, that in many cases, and at this point, this is anecdotal, but we have enough data to compile it to a study that many of these patients who are identified as chronic pain patient, and for audience that are online, the chronic pain patient, we identify that as patient that we did not find any organic reason for their pain, meaning that we did a certain number of tests and we couldn't find the pathology that described the pain. We call them chronic pain patient. What we have noticed in SmartSpine that many of those patients, once we put them through our protocol, for actually more than half of them, we do find organic reasons. So many times, people, even doctors, think our tests are 100%. You get an MRI, there is no pathology, so this might be or must be a illegitimate pain. Whereas our understanding is much more deeper now, and our protocols are exactly supposed to do that. Your first impression cannot be just one imaging and one visit. We need to investigate the matter more before even we call it chronic pain. And the proof of that is we have this huge number of people who has been identified as chronic pain patient. Once they go through our protocol or surgical conservative therapy protocol and the diagnostic protocol, then we do find the pathology. Many of them we can help with conservative management, and many of them are literally within 4 weeks, people who have been on pain medication for years, within 4 weeks after the surgery are free of narcotics. So I think we have lots of work to do there. Thank you.